Tiritilli give us a talk about diarrhea in the primary care setting. And so take it away.
Thank you guys. So I'm Emily Tiritilli. I'm a current third year actually applying into GI at this very moment. So you may hear some interview related coverage requests from me through emails later this month. But I'm going to talk to you guys today about diarrhea in the primary care setting. And I got interested in this because I kept seeing this over and over in clinic. I'm at the VA for my continuity clinic, and I would get a lot of patients who come in and say, hey, Dr. Tiritilli, you know, I've had diarrhea chronically for years and it's really troubling to me, and I just want to do something about it. And I would kind of be stuck in terms of how to work it up. So I have no disclosures. So in terms of diarrhea, the first thing to define is, what is it actually? So it's the passage of loose or watery stools, typically 3 in a 24-hour period or more. And it's important to define duration. So acute diarrhea is typically 2 weeks or less. Persistent diarrhea is anywhere from 15 to 29 days, and then chronic is 30 days or more. And we're going to spend most of the talk talking about chronic diarrhea, since this is mostly what people will present with in the primary care setting. So this is a really great chart to pull up if you want to actually clarify, because as I'm sure you guys have noticed, sometimes people will say they're having diarrhea and it's not actually diarrhea, it's actually just normal soft form stools. So this is the Bristol stool chart, well known to gastroenterologists. And the consistencies of stool that are diarrhea are types 5 through 7. So soft blobs, mushy stool, and then entirely liquid stool. And there does seem to be a trend these days of turning this into cakes, just so you guys know. So you can do that if you feel so inclined. It's important to get a really good initial history and get a really thorough history. So certainly everything related to the type of stool, changes in their consistency, certainly number of BMs per day. Definitely ask about any weight changes. And you can ask about the type of stool, like if it's watery or fatty. People will often kind of describe mucousy stools, and I personally have found that people aren't very good at describing their stools, and so that doesn't often help you very much. But things to watch out for are certainly if there's any blood, and then also if they describe things like oil droplets in the toilet bowl, because that's pretty diagnostic for kind of greasy stools. Other things to ask that people will be less willing to share is any episodes of incontinence. You often have to specifically ask about this. And then definitely any pain with stooling, because this can be a sign of proctitis. Other important systemic review of systems, so fevers or chills, to think about infections, any kind of systemic symptoms like ocular symptoms, pulmonary, arthralgias, thinking about a more systemic process going on, rashes, and then always thinking about malignancy as well, and fatigue and night sweats. Do ask about foods that people are eating if they're having more intermittent diarrhea. You can consider asking them to keep a food diary if it's only maybe a few times a week, to see if there's linked to any foods. And then sometimes it'll be kind of hidden foods. So sugar alcohols, things like xylitol, which is in chewing gum. People don't often think of that as causing diarrhea, but it does. And then obviously lactose and fructose are 2 big players in terms of causing diarrhea. There are definitely the sort of step type questions, so recent travel and hiking and backpacking, drinking river water, that kind of a thing. And then definitely ask about social history, including certainly any alcohol use, and then sexual history, particularly risk factors for HIV, and then if they practice receptal anal sex. Important to know if they have any history of abdominal surgeries. Definitely ask about family history. These 3 are kind of the big players you want to ask about: malignancy, celiac disease, and IBD, but also if there are any other issues in the family, and then meds, and then also ask about recent life stressors. I've actually seen this a couple times over the past few months, especially during COVID times. Everyone is very stressed out, and there's a lot of life change happening, and that will sometimes manifest as diarrhea without any sort of other etiology. Certainly something to think about and ask people if that's been occurring for them. These are the red flags you have to ask about every single time. So any weight loss, rectal bleeding or blood in the stool, nocturnal diarrhea that wakes them up, any lab findings like anemia or hypoalbuminemia, and then on physical exam, any abdominal or rectal mass, and then any family history of colon or ovarian cancer or an older age with a first presentation of new symptoms. Any of these warrant immediate referral to GI for further workup and probably a scope. So I have sort of whittled down the initial workup that I like to do to these few tests, and I'll sort of walk you guys through them. So definitely get a CBC to look for anemia, and BMP to look for any electrolyte deficiencies, certainly renal dysfunction. You could think about LFTs if you're worried about their albumin or protein levels, that they're not keeping up with their nutrition needs. Always check for celiac, and so the way you do this is an IgA anti-TTG level, which is the anti-tissue transglutaminase, and then also get an independent IgA level. About 5 to 10% of people are IgA deficient, and it can give you a false negative. Always screen for TSH because it's just such an easy test to do. And then if you are able to get a stool sample, which I know is kind of a big ask in the primary care setting, a fecal calprotectin is a really great initial screening test. It's a measure of neutrophil activity kind of in the bowel wall, and it's a marker for IBD. The sensitivity and specificity aren't actually super great. It's really just in the 80s, but we typically use it as an initial screen for IBD, especially if you're worried about it in the primary care setting. I've seen people order CRP and ESR in the past. I would say in general, ESR is not really one to test or to order. And then the AGA actually also recommends against CRP as well, because their sensitivity and specificity of particularly picking up inflammatory bowel disease is in the 70s. To me, that's not honestly the worst, but it's also not the best either. So if you have other reasons to order a CRP, go ahead and order it, but it's not the greatest initial screening test. If you're worried that they have diabetes, they have risk factors for it, or similarly HIV, certainly screen them for these. And then if you're miraculously able to get stool studies, which again, I know is kind of hard, definitely test for, do a stool panel and test for infections, looking for particularly for C. diff and Giardia that are two big culprits for chronic diarrhea, and then potentially other infections as well. The main kind of buckets you want to sort people into are, is this an infectious diarrhea? Is this an inflammatory diarrhea, or is it not? And that will really help you in terms of management and deciding whether or not you want to refer to GI as well. Imaging is not typically a first line test, but you should consider it if you're thinking about malignancy in someone, if they have risk factors or a family history, or if you're worried about pancreatic insufficiency in them. So this in particular is sort of one of the reasons I wanted to do this talk, is that there are a lot of tests that are actually not helpful. And I personally have ordered some of these before realizing that they're not helpful, and wanted to look more into this. So we'll kind of go through these. So stool fats, actually there's one type of test called the Sudan stain, which is like a spot stool testing. That's an okay test, but not great for picking up fat in the stool. And the true stool fat measurement requires 48 to 72 hours of stool collection, which is a big ask and really hard to do. And frankly, doesn't actually help you that much in terms of management or sort of algorithm decisions. And so generally, definitely don't order a spot stool test, stool fat test. And if you're thinking about a 48-hour collection, that's really more when it's time to refer that person to GI. Similarly, stool bile acids require 48 hours of collection, which is very difficult for most people to do and is not generally a very helpful test. We'll talk more about stool lights on the next slide, but these are not tests that I order. And then stool O and P, the AGA actually recommends against routine screening for stool O and P, unless you have reason to suspect they have that type of infection. So they have recent travel history or immigration from a high-risk area. Stool leukocytes, you should actually never order. They can indicate bacterial gastroenteritis, but if you're lucky enough to have a stool sample, you would just see that on the stool anyway, or the stool panel. Or they can indicate IBD, but we also have the other test for that. And so they overall have a poor sensitivity and specificity, and in general, you should never order these. And then similarly, stool elastase. It's sort of touted as a marker of pancreatic exocrine deficiency, but it also has very poor sensitivity and specificity when you actually look at it, unless there's very severe deficiency present, and then you will be able to diagnose that through other means. If there's mild to moderate pancreatic exocrine deficiency, this test will not help you. And so basically all of these I don't order. And then talking more about stool lights. So we've all heard about secretory and osmotic diarrhea. And I will say this is not something that's even widely known among gastroenterologists. This stool lights still come up on, I've heard, the GI in training exams, and people will still talk about this, but the sort of basic definition is that you have to calculate this fecal osmotic gap. And so there's this equation and you calculate it using the stool potassium and sodium. And then secretory and osmotic have these different cutoffs. But if you go back and look at the studies for these, they're all awful. So, I mean, if you look at these dates down here, these are like the 80s and the early 90s. And then what they basically did was, this was actually for a while not scientifically validated at all. And then they ended up validating it using quote unquote healthy subjects, which were actually med students that they induced diarrhea in by feeding them these different types of solutions and seeing what kind of diarrhea they had. And they actually found there's some conflicting data. If you read this one study that they gave them this one thing, sodium sulfate, and then it caused a gap less than 50, but it was still osmotic. So basically my takeaway is that this is completely unhelpful. And then also, it can be affected by storage of the stool, length of storage. If there's bacteria in the stool, they'll digest things. And then if you look at all these studies, some of them are in kids and some of them are in adults, and sometimes it's acute gastroenteritis, and the cutoffs have varied. And so it's just not very helpful to me, and not seemingly very evidence-based. And so I don't use it, and I recommend that you guys don't use it either. So I'll just touch briefly on acute diarrhea. Most of the time you probably won't be seeing this in primary care clinic because this is something that's largely self-limited and self-resolves. Just a couple quick notes. So norovirus is the main cause of acute gastroenteritis in the United States, causes 50% of illnesses. Always certainly evaluate for any red flag symptoms. So certainly blood in the stool in particular is a bad sign and a sign that something else might be going on. And certainly if they're dehydrated as well. If you are offering people supportive therapies or counseling them, the WHO recommends this oral rehydration solution, which is basically Pedialyte or these other types of solutions. And then the IDSA actually recommends against Gatorade. I know that everyone talks about Gatorade for rehydration, but they don't find this to be the best solution for rehydration, and definitely not apple juice or soft drinks. And then people always have these thoughts about diets, and patients will ask you about this, like, should I avoid food? And the recommendation is actually to do early feeding. The evidence is that it decreases intestinal permeability and reduces symptom duration. And then there's all this talk about the brat diet, so bread, rice, applesauce, and toast, or that you shouldn't drink milk while you're having diarrhea. There's no evidence for that. You can just counsel your patients to eat whatever they're comfortable with eating and whatever kind of settles well with them. We'll talk more about meds later, but there's some symptomatic medications you can offer them, loperamide and simethicone. And then just watch out for, someone might be coming to see you and maybe in early stages of infectious chronic diarrhea. And so keep these things in mind, and we'll talk more about them in the next couple slides. So C. diff, so as you may know, the name was recently changed. It's now Clostridioides difficile and not Clostridium difficile. So as we all know, it can have a wide range of presentations. Some people can be asymptomatic carriers, and then other people can have life-threatening illness from it. It's mostly fecal oral transmission, but also lives on surfaces, and counsel your patients that the surfaces, spores can survive on surfaces for 5 months. So if they have C. diff and they're living with other people at home, they should really thoroughly clean their house, and it needs to be that specific type of bleach wipe that kills the spores. So obviously antibiotics are the primary risk factor, but if you're seeing someone in clinic who you're wondering if they may have C. diff, just know the risk persists for 3 months after antibiotics have been discontinued. So don't be fooled if they have a more remote use. And then PPIs are certainly also a risk factor. There's various ways of looking at the data, but one study found that 28% of people with community-acquired C. diff had recent PPI use. So, certainly potentially contributes to it. The diagnosis, there are all these different stool tests and assays, and the end result is that the facility will do a stepwise confirmatory approach. And then an important thing to counsel your patients on is that recurrence is common. About a quarter of people have one or more recurrences, and so they should be on the lookout for that. And at that point, you will need to start thinking about second-line therapies or even fecal transplant. And then in all patients, avoid loperamide. And this is why it's important, if you're worried about C. diff at all in someone, to get a stool study and confirm the presence of it, because in sort of other bacterial gastroenteritis, you can give loperamide, but not in C. diff. And then this is sort of the initial episode management of C. diff. And then generally, as we know, the guidelines changed recently. Metronidazole is no longer first line. It's just vanc-PO for 10 days. Fidaxomicin can also be done, but it's typically not as readily improved by insurance. Traveler's diarrhea I'll also talk about, because this is an important thing for all of us to recognize. It's the most common travel-associated disease, affects even a majority of travelers, and it's most commonly E-tech. All the things I read about it say it's frequently self-limited. As someone who has personally experienced this after coming back from Nepal, I can tell you that sometimes it's not, and sometimes you do have to take antibiotics to really treat it completely. And the first line antibiotics antibiotic is azithromycin. You can either give it once or for 3 days. There's high quinolone resistance in the areas that people go very frequently, like Southeast Asia and India. And this is likely because previously the trend was to just give people Cipro as kind of a prophylactic therapy and just tell them to take it as they felt symptoms, which is actually no longer the recommendation. So do not use prophylactic therapy in most patients, and particularly not Cipro. You could think about it for people who are at risk for severe disease. So kind of the standard things we think about: immunocompromised folks, diabetes, end-stage renal disease, and certainly intestinal pathology. The other thing you want to think about is you can treat these folks empirically if they have reported recent travel and it seems like it's traveler's diarrhea. But if they fail their empiric therapy, the symptoms are lasting for a long time, or they have any blood in the stool or dysentery, that's when you need to work them up further with an O&P and then a pathogen panel. So IBS, diarrhea subtype, we'll spend some time talking about this because this is one of the most common causes of chronic diarrhea that you will see in the primary care setting. So it's a pretty significant global prevalence, and it generally occurs in people under the age of 50. There are these Rome-4 criteria, which are pretty specific. So they have to have recurrent abdominal pain 1 day or more per week in the last 3 months, with 2 or more of the following features, which is related to defecation. Typically, people report that their abdominal pain improves with the bowel movement, that it's associated with a change in stool frequency or form or appearance. And very importantly, it has to have been going on for at least 6 months. So particularly now during COVID times, I've seen a couple people come in who say, I've had a month of diarrhea, I'm worried I have IBS, but that does not meet the criteria. You have to have it for a long time. People have sort of variable descriptions of their stool, but it's mostly watery diarrhea, sometimes mucus, never nocturnal, and then often following meals. And then it's exacerbated by emotional stress. And frankly, there's a lot of crossover between irritable bowel syndrome and mental health disorders like depression or anxiety. It can also be related to eating. And then there's also a form of IBS that can be due to a recent gastroenteritis or bacterial infection. And so you can see someone who maybe had some traveler's diarrhea and then just has these chronic symptoms for months or even years afterwards. An important thing to know is that if you're seeing someone in clinic, they meet the Rome-4 criteria and they have no alarm features, you actually don't need to do any further testing. The exception is people who are presenting at an older age, generally over the age of 50 with first-time symptoms. These people always need further workup, and you cannot just stop there. They typically need a referral for colonoscopy. So we have a lot of therapies for IBS. The one I like the most is psyllium, which is obviously a fiber. It's effective in both constipation and diarrhea, so it's really great at regulating the stool. An important thing to counsel people is that a lot of people will start with the biggest dose, which is sometimes a teaspoon or even a tablespoon, and that will give you just horrible pain, abdominal pain and bloating. So you always want to counsel people start very, very small, like a quarter of a teaspoon once a day, and kind of work up to a dose that is effective in regulating your stools, but you can take it up to 3 times a day. It's kind of an unlimited medication. There are also antispasmodics, so dicyclomine, bentyl, and then for people who like more natural remedies, there's peppermint oil. Rifaximin is something that is used in IBS. And then there's this new medicine called Viberzi, which is this fancy mu receptor agonist. It was approved 5 years ago. It is not generically available and it is super expensive. 60 tabs is a 1-month supply and it costs $1,400. So if someone doesn't have insurance, this would probably not be an option for them. There's all this discussion about probiotics. Sort of the most common ones are Bifidobacterium and Lactobacillus. There's some evidence for them, but frankly, it's not great from several meta-analyses. And they actually, well, people will always ask, should I just eat more yogurt? And Activia has done this like big branding campaign to make themselves seem like they're good for gut health. But there was actually a study done specifically with Activia that looked at whether this is effective for treating IBS symptoms, and it's not. So don't counsel people to eat yogurt unless they want to. And then there's a low FODMAP diet, which we'll talk about more in the next slide. And if someone is willing, there's also antidepressants or CBT, which can actually be very effective in reducing symptoms. And there's a whole mind-gut connection that there's a lot of research going into. The low FODMAP diet is something that you hear a lot about. FODMAPs are these fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. It's basically short chain carbs that are poorly absorbed and then rapidly fermented, and then they cause all this gas and bloating and discomfort in people, or at least that's the theory. As you can see, this is a very long list of foods, including some of my favorite foods. And also you could never have flavored food again because onions and garlic are both on there. So it's a very difficult diet to adhere to, as you can imagine. And then there are certainly studies that show that a low FODMAP diet is effective in reducing IBS symptoms. But also there's another study that compared low FODMAP, low gluten, and then a quote unquote balanced diet, which was basically a Mediterranean diet. And it showed that all 3 are effective at reducing symptoms. And so you wonder if people are just eating a lot of things that have like high fructose corn syrup or these sugar alcohols like sorbitol and xylitol that are causing these symptoms potentially. You can also, if people find it too hard to do a FODMAP diet, you can also ask them to just do a food elimination diet, which they may find a little bit easier, is eliminating either all foods at once or just one at a time. Inflammatory bowel disease, I'll only touch on briefly because this is obviously a whole talk in and of its own. And I'll just kind of give you some pearls in terms of recognizing it, but these people obviously need referral. So people with a first presentation of IBD or Crohn's or UC will frequently report small volume stools, tenesmus, which is the sensation of incomplete evacuation or blood in the stool or pus. But don't be fooled if they don't report blood in the stool. That's not always present. Most commonly, they'll report diarrhea, abdominal pain, weight loss, and fever. And so those are, again, some of the alarm symptoms that we need to ask people about. Most studies do report this bimodal distribution in terms of age of onset. So either at a younger age, 15 to 40, or an older age, 50 to 80. It does tend to run in families, so always ask about family history, and it's more common in people with Jewish ancestry. If you're able to get a fecal sample, screen with fecal calprotectin, and then always refer people to GI. These are people who need a scope and further therapy. Microscopic colitis I wanted to touch on briefly because it's something that people don't always know a lot about. It is actually a subcategory of inflammatory bowel disease. And we always think about it as this sort of older age disease, and it does typically happen in people at an older age, but a quarter of people are under 45. So certainly don't rule it out by age. And people will typically report persistent nocturnal diarrhea that doesn't respond to fasting. So sometimes they'll stop eating to try to see if that helps their diarrhea symptoms, but it doesn't. It's actually pretty prevalent. It can cause up to 10% of all chronic diarrhea cases, and we don't unfortunately know exactly what causes it. GI infection is a risk factor, autoimmune disease, and smoking, and then actually meds as well. So NSAIDs, particularly more than 6 months of use, of pretty heavy use, PPIs or SSRIs, which is unfortunate because I don't know about you guys, but basically every single person in my primary care clinic is on one or more of these medications. So everyone is at risk for this. But you can only diagnose this through biopsies during colonoscopy. One of the hallmarks of this is that the colon actually appears normal, and then the therapy is budesonide for several weeks, and some people do require maintenance therapy as well. A quick note about specific populations. If your patient has HIV or you're worried they have HIV, certainly always think about an HIV-associated infectious diseases. C. diff is actually still the most common cause of diarrhea in HIV, causes about 50% of cases, but also E. coli, even types of E. coli that would cause a fairly mild illness in other people. Obviously cryptospore, CMV, and then MAC can cause digestive symptoms if it's disseminated MAC in people who are very immune suppressed. So you do always want to get a stool sample in these folks. Think about infiltrative diseases, so lymphoma or Kaposi sarcoma can present this way. There is this HIV-associated enteropathy that's just unfortunately kind of associated intrinsically with HIV, and then meds, particularly protease inhibitors, are also associated with this. And then it's important to ask people if they're practicing receptive anal intercourse, because gonorrhea and HSV can cause proctitis, and that can present with diarrhea. So malabsorption syndromes are another really common cause of chronic diarrhea, and this is kind of the big umbrella term for a lot of different things. Classically, people will report that they're very bloated, they have abdominal distension, and then they'll have these pale, fatty stools, large volume, and maybe some weight loss as well. If you're worried about this, you should definitely get some lab evaluation. So anemia is pretty common. You want to work up why they're anemic, and then also fat-soluble vitamins, and then other mineral electrolyte deficiencies can be present. So the sort of common ones that we think about are lactose intolerance. If you're suspecting that, you can ask people to cut out lactose and see what happens. Celiac disease, obviously we start with serologic testing. An important thing to note is don't ask people, if you're thinking celiac disease, don't have them eliminate gluten prior to the colonoscopy, because it will eliminate the sort of characteristic findings on colonoscopy, and then we won't be able to pick it up on biopsy. Pancreatic exocrine insufficiencies, somewhat common. People are at risk for it if they've had a history of chronic pancreatitis, or certainly a history of alcohol use disorder, and potentially leading to chronic pancreatitis. And in these folks, as we were talking about before, there aren't good tests for this. So if you're suspecting this based on someone's history or their other medical issues, you can actually do an empiric trial of pancreatic enzyme supplementation if you think so. And if it doesn't improve their symptoms, you just take them off. It's fine. And then mesenteric ischemia, obviously we know there are vascular risk factors involved, and then the sort of classic abdominal pain related to meals. SIBO, or small intestinal bacterial overgrowth, is this kind of very wide-ranging diagnosis that can be caused by a lot of things. But think about SIBO if someone is presenting with sort of similar symptoms to IBS, so bloating, abdominal pain, diarrhea, lots of nausea, but not a lot of vomiting. It does require a breath test to diagnose, and so that if that's not available in the primary care clinic, that will require a referral to GI. And then there are these much rarer etiologies of malabsorption syndromes, so infiltrative diseases, malignancies, and then chronic infections. We always learn about Whipple's disease, and they're always testing us on it, but just so you guys know, since the 80s, only about 30 people a year are diagnosed with Whipple's disease, so it's definitely not super common, but never an impossibility. It's important, if you're thinking about celiac disease, to actually do a really good skin exam and ask people about any rashes. There's this very classic rash called dermatitis herpetiformis that very strongly suggests celiac disease. I've included some pictures of it here. As you can see, it's kind of a non-specific rash, and people might just think it's eczema or dry skin or something like that, but it can point or suggest celiac disease if you see it or if they're reporting it. And then there are all kinds of issues that can happen when people have abnormal anatomy in the abdomen. So particularly malabsorptive and motility disorders in the setting of surgeries previously. So gastric bypass and really Roux-en-Y are huge culprits for causing all kinds of GI issues and a lot of diarrhea as well. And they also short bowel syndrome, which can be certainly due to bowel resection or even tissue ischemia in the setting of sort of chronic, poorly controlled Crohn's disease. And when people have this, any kind of anatomic abnormalities, it's also a risk factor, again, for SIBO, which is this bacterial overgrowth, which will cause all these symptoms of nausea and pain and bloating. Any history of radiation can cause a radiation colitis, which is a type of inflammatory diarrhea. They will sometimes report blood in their stool. And these can actually happen even years after exposure to radiation. So always keep this in mind if someone's had a history of abdominal or pelvic radiation. And then bile acid malabsorption or bile acid diarrhea is one that has sort of a range of potential causes. The classic one is this post-cholecystectomy diarrhea, that for a while after cholecystectomy, people will just have poor absorption of their bile acids and it causes this diarrhea. The bile acid is resorbed in the terminal ileum. So if anyone has had an ileocecectomy or terminal ileal disease in the setting of Crohn's or other IBD, you should think about this. And then again, any abdominal radiation. And again, the stool studies for bile acids are difficult to do, and they require this 48-hour stool collection. So if you're suspecting this, you don't need to test people for that. You can actually just empirically trial bile acid binders like cholestyramine. If you have a strong suspicion for this, they're pretty safe medications. They'll just cause some abdominal pain and bloating potentially, but if you find that improves their symptoms, that's great. If they try them for a month and it doesn't improve them, then you can just take them off. And then you always want to ask about meds. As any good primary care doctor, you always want to review what meds they're on and what meds may not even be on their list, but that they're taking at home. So ACE inhibitors are actually a culprit in this. Obviously, we all know antibiotics and metformin are huge causes of diarrhea. Things that we use commonly in the primary care setting are colchicine and NSAIDs, which can contribute to chronic diarrhea as well. Propranolol and simvastatin are very common meds. And then there's obviously this whole host of medications that cause diarrhea. It's one of the most common side effects of meds, but these are some of the sort of bigger hitters. And then definitely ask about things like caffeine. And then also if they're taking anything that is actually acting as a stimulant laxative that they may not even know, like magnesium, for example. And then there are other sort of rarer and less rare etiologies that you just think about in terms of the right clinical context. So if you're worried about malignancy, neuroendocrine tumors and VIPomas will do this. These are very rare. Colorectal cancer can present for the first time this way, but that's uncommon. And then lymphomas or pancreatic cancer. There is a phenomenon called diabetic diarrhea, and it's just this kind of long-term autonomic neuropathy of the gut, essentially. It can happen in either type 1 or type 2 diabetes. Certainly alcohol use disorder predisposes people to diarrhea. Cystic fibrosis, if there's pancreatic exocrine deficiency. So ask people about pulmonary symptoms and just remember that sometimes people are undiagnosed with this even into adulthood. Hyperthyroidism, obviously, so always screen with a TSH. And then, as we all know, you can actually have fecal impaction or a really severe constipation, and then that can cause incontinence and episodes of diarrhea. This is typically in older adults. And then there are these two last diagnoses. So factitious diarrhea, it's basically kind of like a Munchausen's diarrhea where people are sort of either putting urine in their stool or things like that to try to make it seem like it's more like diarrhea. Sometimes are often seen in women working in healthcare settings, and sometimes they'll be abusing laxatives. And if you're all concerned about this, you can screen them with a urine for looking for laxatives. And then functional diarrhea, sort of the dreaded diagnosis of exclusion that is very similar to IBS, but then doesn't have those features of abdominal pain and bloating specifically. They just have diarrhea, sort of unknown cause, and you've worked them up thoroughly, and you don't have a good explanation for it. So there are some symptomatic therapies. There aren't a whole ton, unfortunately. So the big one is Imodium or loperamide. Obviously, as we talked about, if you're worried about infectious diarrhea, fever, abdominal pain, or certainly if there's bloody stool, contraindicated. And then just for everyone to know, this is often abused as well. It does have action on the mu receptor, and at very high doses, it will cross the blood-brain barrier. And so people will take it at very, very high doses to get that effect, and then have to do things like manual disimpaction. Pepto-Bismol is another common one that's over the counter. Something that not a lot of patients might know is that you can only use it for 2 days duration max. So you shouldn't be just taking it every day if you're having this chronic diarrhea. And then since it is a salicylate, you want to take care in recommending it to people who have other anticoagulants, and certainly people who are pregnant, and then gout, type 2 diabetes, or HIV. You do also want to warn people if they are taking it for the first time that it can turn their stool black, and it can actually also turn their tongue black if it's the uncoated formulation. So methicone is one that people will use, and you can recommend it if you're sort of out of options, but frankly, it's not very effective. Gastroenterologists that I've talked to say they don't typically recommend it. The actual most common use of it in the field of gastroenterology is during colonoscopy. We'll squirt it at gas bubbles in the colon to get rid of them. But systemically, it just doesn't work quite as well. And then there's this other medicine called crofelemer, which is for HIV patients. It's a chloride channel blocker, and you use it specifically in non-infectious chronic diarrhea that's either caused by this enteropathy or by the medications we're giving them. People will ask about probiotics, and they're certainly welcome to take them. There's sort of mixed evidence about them in chronic diarrhea, but I would recommend against using them as sort of non-specific empiric therapy if you're not sure what else is going on. You really want to make sure to do a thorough workup in these people. So just a few key points, and I'll leave this here in case people want to screenshot it, but the initial workup that I recommend when you're seeing someone for the first time in clinic, CBC, BNP, consider LFTs, TSH, celiac, serologies, and if you can get stool studies, screen for stool infections, particularly Giardia and C. diff, and then fecal calprotectin. Do not order these other fecal studies, fats, whites, bile acids, lights, and O&P and elastase. They're not particularly helpful, or they take much too long to collect. Definitely screen every single person for red flags: weight loss, rectal bleeding, nocturnal diarrhea, anemia, hypoalbuminemia, and then family history or an older age of symptoms. And then this merits an automatic referral to GI, and they'll probably get scoped. Always sort people into categories of infectious, inflammatory, or not, and then kind of make decisions about management from there. And then just another couple key points: if they meet criteria, Rome criteria for IBS, and they don't have any red flags, you can just stay there and you don't have to test them further, except if they're older. And then you can also do empiric trials of certain medications, including pancreatic enzymes or bile acid binders, if you have a strong clinical suspicion. So these are my references. I'll open it up to questions in just a couple minutes, but I have one last pearl about Melana. I feel as my due diligence as a hopeful future GI fellow to pass this along, because I found this very helpful as a resident. So for people who haven't seen it, this is what melana looks like. And if you're doing a rectal exam and wondering if it's melana, you should bring either a pad or a paper towel, something that's white, and then wipe the stool that you have on your finger from the rectal exam on that. And then melana will appear very dark, but then either have a red base. This is like really red. It's usually not like that. And then it might look green as well, or can be kind of in between these two. And these are pictures I got from the internet, but this one here is a picture I took at our very own VA Puget Sound as an intern of melana in a toilet bowl of one of my patients. And as you can see, it does have this kind of green base on the white background, and that's what it will look like. So I'm happy to open it up to questions at this time.
Some questions from the chat. So question about, do you know at our outpatient clinics what infection tests look like? Are we talking a stool PCR or a biofire, or maybe helping us understand like when to order a biofire? And then a separate but related question about the stool O&P and being told that it's such a cheap and easy test that maybe we should do it, but it sounds like actually it's not that helpful. So thoughts there. Okay.
So I can only speak to the VA. I think at the VA, I typically order the BioFire just because it is so comprehensive and it does have C. diff already in it. And so that's kind of the big thing that I'm looking for, because that's the one that we can really act on with therapy. I think it's also reasonable to, if someone's presenting with acute diarrhea, they're really wanting to know what's going on, you can just screen them to make sure it's C. diff, but otherwise provide reassurance. I think, there's all this question about over testing, but sometimes it is nice to provide patients with an answer of like, oh, hey, you have EHEC, and we know what it is and it's self-limited. But my general principle with testing is to, if you're looking for infection in the stool, to test a little bit more broadly as well. It can also give you a clue, like if someone's coming in with chronic diarrhea and they have an infection in their stool, like EHEC, for example, that should typically cause a fairly self-limited course, you can wonder if there's maybe some immune suppression present, or there's some other reason why this is turning into a kind of a chronic diarrhea picture for them. And then, yes, O&P, the AGA recommends against it. I typically don't order it unless someone is coming from a high-risk area, like a typically middle and low-income country. Other questions?
I guess while other people are composing questions, one question from earlier in the chat, the concern with nocturnal diarrhea specifically is being a red flag symptom. Can you comment on that?
Yeah, I haven't found any studies that specifically say why, but I think that the general thought is that IBS really shouldn't be causing that. IBS is something that is often precipitated by meals, and so if they're having sort of uncontrollable diarrhea that wakes them up at night, you would think more about a sort of either inflammatory process going on, or something that is not related to sort of a more functional disorder particularly. And so it sort of makes it a little bit more serious of a diarrhea, if that makes sense. Any other questions?
Do we have, so I feel like IBS is really common, and people have a very difficult time adhering to some of the elimination diets, because the choices are slim pickings, as you showed, based on the
Yes.
chart of foods to avoid. Do we have, well, you're at the VA, so this might be different, but do we have resources for like comprehensive treatment of these patients, since you're saying how treatment with pharmacologic therapy for other coexisting mood disorders or sometimes CBT can be helpful? Do you know if there's resources at UW for these patients?
I don't know. I think from talking to the UW GI department in particular, they definitely have some people who are sort of functional disorder specialists. And there are some hospitals or clinics that have like a kind of a comprehensive clinic where there are social workers and psychologists and things like that. I don't know if that's present at UW. I think they're talking about it. But I think in general, if you don't have the luxury of having such a sort of sophisticated clinic at hand, it can be a good way if someone, typically if you're worried about a mental health component, that will be features of depression or anxiety in the patient, and it can be a great platform to say, hey, you're having these symptoms and I'm concerned that there's a connection to your mood as well, and kind of get that to as a way to encourage them to go to therapy if they're more reluctant to do that. But sometimes, unfortunately, the care does just have to be divided that way. But yes, to sort of answer your question in a very long-winded way, I'm not sure exactly what specifically the resources at UW are, but I think they're working on it. Okay. I think,
Maybe just one last question before you wrap up. Someone in the chat is curious about HIV patients and the specific therapies for them, and if you've had any experience using them in your clinic, or if that's more something that the ID team is recommending, or GI, or how you
yeah,
evaluate that.
I don't know. Actually, I've never personally used crofelemer. I actually don't have a lot of HIV patients in my clinic. And I mainly came across it when I was researching this talk. And so I found it interesting. I didn't know that it existed. And so I put it in as kind of a, hey, this is available on the market. But I think people at Madison Clinic would probably be the sort of resources to ask about that, about how often do we use that. I personally have never used it. So it's hard for me to speak to that.
Okay. Thank you so much, Emily. That was so awesome and so comprehensive. I loved your slides about like recommended workup, and I personally screenshotted them too. So thank you. So everyone, I think we will take another 10-minute break. Interns, actually, you are off to Zoom to Mega Intern Report, and Courtney just threw the link in the chat. So thanks for joining us, and we'll see you next week, but enjoy Intern Report. R2s and R3s, we will see you back here in 10 minutes, and then we will go from there.